I'll be talking to us in the next few minutes on auditory evaluation of stroke survivors, validating a low-cost screening protocol. This work received funding as part of the ARUA Center of Excellence work on non-communicable diseases. I'm going to follow the outline here. We started it, we got our grant letter earlier in the year, and we started work. But let's go ahead to my presentation. Auditory impairment is the most common sensory disability in the world. And it has a very significant impact on functional ability at personal, social, and occupational levels. Adult onset auditory impairment is the third leading cause of disability worldwide. It is pertinent to point out that Sub-Saharan Africa, Southeast Asia, and some parts of South America has the highest burden of hearing loss in the entire planet. Stroke is the commonest neurological disorder in adults. It is a leading cause of medical coma, neurological disability, and placement in long-term care. Globally, stroke is also the second most common cause of death. In Sub-Saharan Africa, we also have the honor of having, which I call the global honor of having the highest incidence and prevalence of stroke worldwide, and the greatest case fatality among stroke patients. That is indeed the ignoble honor. Stroke survivors often experience depreciation in their quality of life, and they most likely will require long-term care. Post-stroke disability has a profound impact on the patient. It does on the caregivers, their loved ones. It does also have imposed a significant burden on the society, and it is a significant contributor to healthcare expenditures. It is said that about a third of all stroke survivors will be functionally dependent on other people at least a year after the onset of the stroke. Because auditory impairment does occur along with stroke, this can lead to hindrance in patient care, and it also could cause obstacles in rehabilitation of the stroke survivors. Acute hearing loss is quite common in elderly stroke survivors, and an association between hearing loss and stroke has been identified. And it shows that in about 80% of stroke survivors, they will come down with hearing loss. Also, comparison of age-related hearing loss with age-matched normal hearing control shows that there is a higher prevalence of stroke in individuals with hearing loss. And this is also seen in that people with stroke are likely to develop, that is stroke survivors, they're likely to develop defects in cognitive function. And it's also known that individuals with hearing loss have a greater risk of developing dementia. So when we now have hearing loss in stroke survivors, it means that it worsens the likelihood of developing loss of cognitive function in this category of people. Also, there's an higher risk of sudden sensorineural hearing loss among stroke survivors. So post-stroke rehabilitation programs, which are designed to help the patients become more independent, become hindered when hearing loss exists, because the hearing loss will hinder communication between the patient and the healthcare providers, so to lead to unsuccessful rehabilitation programs, poor functional outcomes, and to cause these stroke survivors to become socially withdrawn. Because of the limited resources for acute care and rehabilitation of stroke patients in Sub-Saharan Africa, there is limited rehabilitation efforts, which is oftentimes frustrated by either undetected or late detection of hearing loss among stroke survivors. So what is the gap in knowledge? There is significant underestimation of post-stroke hearing loss, with up to 86% of cases undetected in patients who are assessed within 10 days of the onset of the stroke. The true prevalence of hearing loss in stroke survivors is still unknown. The underestimation of the post-stroke hearing loss could be due to various factors, such as the inadequate examination for hearing loss during the stroke or post-stroke period. It could also be due to the difficulty in executing routine hearing protocols among stroke survivors. So if we can have guidelines related to screening, assessment and evaluation of hearing loss in stroke survivors, it will be pretty effective, it will be advantageous. Currently, we have insufficient data in the sub-Saharan population to plan adequately for interventional programs that can improve functional hearing outcome in stroke survivors. So let me just move further first, though I think I'm good with time, so maybe I could try to read to all my slides. Although hearing loss is observed in cerebral stroke patients, the mechanism is still unclear. We know that in cases of ischemic stroke, the auditory pathways could be involved, and that has been postulated as the possible cause of the mechanism of hearing loss that is seen in stroke patients. Also, ischemic stroke survivors have 80% increase in the risk of developing sudden cerebral hearing loss compared with non-stroke survivors. So, looking at neuroimages among stroke survivors to provide explanation on the relationship of the stroke subtypes to the hearing loss. So, what is our justification for this one? Multimorbidity, which is one of the things identified in the earlier presentation on the NCD Center of Excellence, is a common pattern that is seen in chronic ailments. It inflates healthcare costs due to complicated treatment plans, and it leads to reduction in the quality of life of affected individuals. So early identification of multimorbidity will help also design suitable treatment plans that will be adequate for patient management. And this underscores the importance of early identification and management of hearing loss in stroke patients, because we have hearing loss as a morbidity, we have the stroke itself as a morbidity, so we have multiple morbidities in this instance. Having an adequate treatment plan will enhance the patient's ability to communicate, it will facilitate rehabilitation, social engagement, it will reduce the psychological burden, both on the stroke survivor himself or herself, and also on the care providers, including family members, and to potentially preserve long-term cognitive function in stroke patients. Undetected hearing loss in stroke patients could exist if there is only superficial evaluation of these stroke survivors, and that would be sufficient to make accurate diagnosis. Providing comprehensive audiological assessment to all stroke patients in sub-Saharan Africa will be costly, time-consuming, impracticable. So there is need for a protocol that can identify hearing loss in stroke survivors in a cheap, reliable, and swift manner. Currently, such a validated protocol does not exist. Moreover, the protocol that this study aims to validate will make use of middle-level manpower, such as nurses, thus ensuring that reliable identification of hearing loss can be done even if the physician is not physically present. And this can have significant impact on stroke management practices across sub-Saharan Africa. So our primary objective is to validate a low-cost hearing screening protocol for early identification of peripheral hearing loss in stroke survivors. We have secondary objectives, which is to validate the hearing screening questionnaires in local languages on the study site. The Yoruba, as we see in southwestern Nigeria, and also Ashanti, as we see in Accra, University of Ghana, where University of Ghana is. We also want to determine association between site of brain lesion and stroke subtype with occurrence and severity of auditory impairment. So the study is a study of diagnostic accuracy using sensitivity and specificity. We want to validate a modified hearing screening protocol for use in sub-Saharan Africa using data collected from Nigeria and Ghana, and we among sites, particular sites of the Siren and Sleep genomic study. This Siren/Sleep genomic study is the largest stroke study currently in Africa. We intend to recruit a minimum of 100 stroke survivors with 3 to 12 months or 3 to 12 months post onset of stroke. The time frame is closing because it is at this period when auditory impairment in stroke survivors is expected to be stable. The inclusion criteria are adults that are aged 18 years and above with clinical stroke, and also with neuroimaging confirmation. Also, the exclusion criteria are stroke survivors with severe hearing loss or worse, comorbidities such as severe aphasia or significant psychiatric illness or severe concurrent medical illnesses. So for the screening tool, we intend to use the AirWoo. The AirWoo is a smartphone-based screening app that was launched by the World Health Organization a few years back, which is to help in it is user directed, and the aim is to try to identify or to screen for hearing loss. In addition to this smartphone app, the app is freely available. In addition to this smartphone app, we also want to use two self-reported hearing questionnaires to help us to determine hearing disability. We'll be using the modified Amsterdam Inventory Auditory for Disability questionnaire and the hearing handicap inventory for the elderly. These two instruments translated to the local languages and validated before being administered on the subjects. For the gold standard, we intend to use audiological assessment with the pure tone audiometer. The pure tone average will be determined for each year, and the hearing threshold in the better hair will be selected using the World Health Organization classification of normal, mild, moderate, moderate to severe, and profound hearing loss. This curtain audiometry will be conducted according to ASHA guidelines. ASHA is American Speech and Hearing Association. The curtain audiometry will also be used as reference both for all the screening tests to be using, both the app and the questionnaires. The neuroimages will be reviewed by a radiologist. The classification of the stroke subtype and other relevant information will also be recorded from the case file of the patients. The HEPO app is designed to give a pass or fail reading, which will be noted. The performance of the HHIE questionnaire will be noted. The scoring format is used. Total score that are less than or equal to 16 will indicate normal hearing, while total score that is greater than or equal to 17 will show that there is some hearing impairment. For the AIAD questionnaire, pass is defined as scores, total scores ranging from 64 to 84, while any score that is less than 64 is failed, which is evident of hearing impairment. So we are going to be looking at the accuracy of these screening tools for diagnosis of auditory impairment by calculating sensitivity, specificity, the positive predictive value, and the negative predictive value of each of these tools. We'll also be looking at the hearing screening app, and we'll be comparing it to the pure tone audiometer. The sensitivity and sensitivity of the questionnaires will also be determined by comparing the results to what is seen from the PTE. The sensitivity will be calculated as a proportion of persons with auditory impairment that are correctly identified by the test, while sensitivity will be calculated as a proportion of persons without auditory impairment correctly identified by the test. For the PPV, we're going to be determining the positive predictive value as the probability of subjects with positive screening tests who are truly at beg your pardon, I take that again. The PPV is the probability that subjects with positive screening tests truly have the hearing impairment, while the NPV, the negative predictive value, is the probability that subjects with the negative screening result truly do not have hearing impairment. So I will just quickly present the preliminary result. The studies are still ongoing. So far, we've been able to recruit 13 subjects. The distribution is seen on the screen. In the pure tone audiometry, the vast majority of them have mild hearing loss, while the rest have normal hearing. The scores for the ARUA, the total score for the two questionnaires are also shown. So looking at the result of the ARUA app, The sensitivity gave us to be 30.77, while the confidence intervals is as shown. The specificity, these results are all shown in percentages. The specificity is 53.85, while the positive predictive value is 66.67, and the negative predictive value is 100%. For the HHI, hearing handicap inventory for the elderly, the sensitivity is 46.15. The positive predictive value is 100. The other two values are given as 0. In the AIAD, the sensitivity is 30.77%. The specificity is 30.46. The positive predictive value is 66.67, while the negative predictive value is 71.43%. Our expected output by the time we're done with the study and we have all our data in is that we'll be able to validate a low-cost and relatively low-tech auditory screening protocol that can provide quick and reliable clinical data for identifying patients with significant auditory impairment, and who probably will require an ENT specialist review subsequently. That is among stroke survivors. We also hope that our study will serve as a template to design protocols for the management of auditory lesions in post-stroke patients. We also expect that our study will be a template for additional studies that will adequately characterize the hearing thresholds in stroke survivors with the aim of achieving good functional outcomes in the management of these patients. The limitation is that this study is limited only to peripheral hearing loss. It won't cover the more complex central auditory processing disorders, which will include difficulty in sound recognition, difficulty in speech and vocalization. We expect that by the time we will proceed with this work, we'll be able to leverage on the Siren6 Genomics platform to seek additional funding to deploy the validated screening protocol and turn it into a standard operating protocol for stroke management across all the participating sites of the Siren6 Genomics network. We anticipate that the available large pool of stroke survivors will enable us to adequately document the impact of the auditory screening protocol in the routine management of stroke patients and be able to determine the effect on the quality of life and cognitive function amongst those survivors. Additionally, we hope that this study will provide pilot data that we can use to seek more funding to explore research into the complex central auditory processing disorders among stroke survivors. Our collaborators include Professor Mayo Wulabi, who's the lead PI for Siren6 network, Dr. Alberto Palu, one of the PIs on the same network from University of Ghana, Dr. Rufus Akemi, one of the co-PI, and both for the Siren6 Genomics platform from the University of Ibadan. Okay, these are my references. Thank you very much for listening.